So how to approach MCQs for your exams? Now remember, it's an MCQ based exams and this entails a separate strategy. So all of you guys will probably be writing theory papers and you have to extensively write a lot. It depends on memory, it depends on handwriting. There's nothing like this. The answer is in front of you. So it entails that you follow a different set of strategy. So we'll be focusing on how to approach MCQs for your exams. So how to approach MCQs for exams, the MS Dhoni way. So as I record this, Chennai has just won its 4th IPL title. So again, MS Dhoni presents an interesting case study and is especially useful even in how to approach your exams. So MS Dhoni accepts limitations. CSK had no mystery spinner, had no tearaway fast bowler. Okay, all their players were pretty much old. They were called the dad's army. So all of this were limitations. He accepted his limitations. He focuses on strength and backs his players. So his strength was experience. He focused on experience. Watson did not play for the entire IPL in 2018. He carried him in the team until Watson scored a century in the final. So similarly, what is your strength? It depends on you. Some people have a very good memory and even if they read once, they probably can recall everything. Some people put in a great deal of effort and learn. Some people are very good at guessing. So if you give an MCQ in front of them, even if they don't know the answer, they can make a pretty good guess. And some people are just lucky. So even luck plays a very important role. So again, focus on your strengths, back your strengths, strategizes and adapts on the field. So again, we live in an age of information overload. So again, you have cricket teams strategizing and planning in their dressing rooms. So again, strategy is very important for you. You need to strategize and make your plans. And again, you need to adapt in the exam hall. So just because if you see an MCQ that you have no clue about, you need to see if you can guess that particular answer. Again, this is very important and this will give you that additional 10 to 15% which might get you a very good rank. And finally, accept outcomes. Again, see, this is not the end of the world exam. You've all done your MD. You have a pretty valid degree with you. Again, even if you get in, it's very good. If you don't get in also, it's not the end of the world. Accept outcomes. So if you can meet success and failure and treat them both as imposters, then you're a balanced man, my son. Rudyard Kipling. So again, MS Dhoni is a pretty balanced man. So again, you should also be a very balanced person in your exam halls. So being pragmatic. So what is pragmatism? It's dealing with things sensibly and realistically in a way that's based on practical rather than on theoretical considerations. See, you have Braunwald, you have Park, you have Perloff, you have your latest journals, guidelines. It's not possible to read all of them together. It's not humanly possible. So again, we learn a very small amount of content and we utilize that content in your exam halls. So again, you should be pragmatic. Even if you see a question of, you will see plenty of questions in your exams from topics you have not studied. So again, being pragmatic is trying to guess an answer for those questions based on your knowledge. And again, this is what we shall be focusing in this particular topic. So how can a question paper be answered? So 30 to 40% of questions are very easy. Again, it's at a pretty basic MD level. Any one of you can answer it. So 30 to 40% of questions are easy. 30 to 40% of questions are based on how well you learn. So again, that is your individual contribution. So if you study very well, you can get a large fraction of these questions. If you don't put in the efforts, again, you won't get this. So this is actually based on how much you learn. Okay, well, what books you read, what is the effort you put in beyond a particular MD candidate. This is basically an MD level. These are questions which you require a dedicated study of your super specialty books. This is what you put in your effort in. And 20% is based purely on pragmatism. So again, the question will be from a topic in which you have not studied or which you don't have adequate depth of knowledge on. However, you can guess an answer. So that's what I'll be showing you how. And 10% of questions are very, very difficult. No one can answer it. Leave them alone. And as usual in any exam, you'll have 1 to 2 controversial questions. No one can help it. So there are 3 types of questions in your exams. The I don't have a clue question. Okay, you see the question, you have absolutely no idea what the answer is. The either you know or you don't know question. So again, you see this particular question, you cannot guess an answer for that. Either you know the question or you don't know the question. And the I don't know, but I can make an educated guess. It can be based on gut feeling, can be based on logic, can be based on ruling out the other options. So this is one we shall focus on today. This is based on pragmatism. So we'll take an example for each of these. The I don't have a clue question. So who is the director of the Framingham Heart Study? So asked in AIMS 15. So again, Framingham Heart Study has multiple directors. They've asked you who is the director of the Framingham Heart Study. The answer was William Cannell. So he was the third director of the Framingham Heart Study. So again, this is a landmine question. Probably no one who writes the exam will know this question's answer. So again, do not guess this. Leave this question particularly alone. So this is a landmine question. So again, the other options are just I made it up. So again, this is just from Harry Potter. For those of you who have read Harry Potter, you will probably get this. So we come to the next landmine question. So Tavarioma is, so asked names 2021. Hemangioma, pericardial tumor, leiomyosarcoma, or cystic tumor of AV node. Again, no one in the exam hall is going to know the answer to this question. It's cystic tumor of AV node. Okay, so remember the AV node was described by a person called Sunuo Tawara. So probably it's in his honor that you call it Tavarioma. Okay. So cystic tumor of the AV node is also known as Tavarioma, coleothelioma, or mesothelioma of the AV node. And this question was asked in NEET 2020. It mainly presents as bradyarrhythmias and complete heart block. So again, remember the different names: Tavarioma, coleothelioma, and mesothelioma of the AV node. Okay. So who described the SA node? SA node was described by a person called Keith and Flack. So Keith and Flack. So it's also known as Keith and Flack's node. Okay. So either you know it or you don't know questions. So these are questions which are from important topics, the topics which you are expected to know. So if you have studied it, you can answer it. Otherwise, you cannot. The landmine questions are questions in which nobody studies those topics. So again, you see this gray score. Gray score is important. Everyone needs to know what the gray score is. But this is a question you cannot guess the answer to. You have to know what the gray score is. So again, gray score for ACS includes all of the following: sex, creatinine, cardiac biomarkers, and age. The answer is sex. Okay, so you can see this here. So this is what the gray score is at admission: age, heart rate, SBP, creatinine, congestive heart failure, cardiac arrest admissions, ST deviation, and elevated cardiac biomarkers. It gives you in hospital as well as 6-month mortality. You have a gray score for admission. This is what I recommend you to learn. You also have the gray score at discharge. Okay, if you can remember, it's nice, but this is very important. You should know the gray score at admission. And gray score of more than 140, you take up for an intervention. So again, gray score of more than 140, you can see the in-hospital risk is more than 3%. You have to do an intervention within 24 hours. Okay. Which channel is involved in calcium-induced calcium release? Again, an important topic. The mechanism of action potential, calcium-induced calcium release, ryanodine receptors, calsequestrin, all of this is a very important topic for your exams. You are expected to know this, but you cannot guess the answer to this question unless you know this. So the answer is L-type. Okay. So again, this is your calcium-induced calcium release. This is your L-type of calcium channel. Calcium enters into the cell, and you have something called the calcium spark. Okay, calcium spark. So this amount of calcium which enters into the cell stimulates calcium-induced calcium release. So through the ryanodine receptors, you have a calcium-induced calcium release. So a small amount of calcium enters through the L-type of calcium channel, and it acts as a spark. So calcium spark, and triggers the release of calcium stored in the endoplasmic reticulum through the ryanodine receptors. So remember, L-type of calcium channel, L is long-acting. It is the one which is involved in calcium-induced calcium release, the so-called calcium spark, and calcium is released again through the ryanodine receptors. This has also been asked. Calcium release occurs through the ryanodine receptors. So again, L-type, most of your calcium channel blockers like verapamil, diltiazem, amlodipine, felodipine, nifedipine, nimodipine, most of your calcium channel blockers block the long-acting type of calcium channels. Again, these are present in muscles. So smooth muscles, either of the vasculature or even cardiac muscles. So these are present, remember, in muscles. The T type of calcium channel is a transient calcium channel. Again, this is present in conducting system. Then you have your P type and your N type. So remember, L plus N channels. This is cilnidipine. Okay, cilnidipine is your antihypertensive. It's very popularly used nowadays because of the decreased incidence of pedal edema. So I'll tell you the quote one of my professors said when I said that you should use cilnidipine. He says cilnidipine is a very wonderful molecule, but the BP won't come down. So remember, your most potent antihypertensive among your calcium channel blockers is nifedipine. then you have amlodipine, and then you have cilnidipine. So cilnidipine is less potent. It has decreased incidence of pedal edema, it is antiproteinuric, all those, but again the potency is a bit low. We have L plus T plus N, which is benidipine. Okay. So remember, most of your calcium channel blockers are L-type calcium channel blockers. So this is the focus of our topic. The I don't know, but I can make an educated guess question. So again, you can make it based on logic, gut feeling, ruling out other options. So again, a lot of mechanisms by which you can make a educated guess. So we'll be focusing on how to make an educated guess in your exams. So this is a question asked in AIIMS 21. So PA banding is indicated in all except asked in AIIMS 2021. So again, not many of you are going to learn about the indications of PA banding. So again, it requires you to make an educated guess. You can just imagine, suppose you are an examiner, you automatically don't expect an MD candidate to study the indications of PA banding. So you want the MD candidate to make an educated guess based upon the knowledge which he has. So again, you can just imagine that somebody is putting a gun to your head and forcing you to answer the question. So the regular student will just think of all these conditions, will just go through the pathophysiology and try to make a guess. The intelligent student will think something like this. So why is PA banding done? So this is the RA, RV. So you put a band on top of the pulmonary artery. So why is PA banding done? PA banding should be done in conditions of increased pulmonary blood flow to decrease pulmonary blood flow. A very logical assumption. So you put a band on top of the pulmonary artery in cases of increased pulmonary blood flow to decrease the pulmonary blood flow. So in which condition should you not do a PA banding? You should not do a PA banding in conditions which have already a decreased pulmonary blood flow. Okay, so PA banding is a procedure which is done in conditions of increased pulmonary blood flow to decrease the pulmonary blood flow to prevent pulmonary edema and recurrent respiratory infections. So the logic is you should not do a PA banding in a condition which already has decreased pulmonary blood flow. So in this, which condition is known to have decreased pulmonary blood flow? The answer is very clear, it is Epstein's. Okay. In fact, if you see the X-ray if you see the pathogenesis of Epstein's which I taught you, this is slide which I had put. In severe Epstein's, the RV suffers miserably. Already a large portion of the RV becomes the atrialized right ventricle. You have the displacement of the tricuspid valve downwards. A large portion of the RV becomes the atrialized right ventricle. Your RV volume falls. Whatever blood enters into the RV regurgitates back into the ARV and RA. So the RV suffers miserably. Already the RV is small. There is severe TR because there are multiple, say, holes in the substance of the anterior tricuspid leaflet. So it is through these holes that you have severe tricuspid regurgitation. So already there is decreased blood flow. Whatever blood is entering into the RV is taken back again into the RA. So the RV suffers miserably. As a result, pulmonary blood flow decreases. So again, this is your echo of Epstein's. The RV is only so much. So again, there is going to be decreased pulmonary blood flow. This is your typical X-ray. I told you, whenever you see your large heart, okay, your first option is Epstein's. In your exam hall, if you see the largest hearts belong to Epstein's. So a typical thing in Epstein's, you have huge cardiomegaly. Sometimes it can be wall to wall, from one wall to the other wall. You have typical oligemic lung fields. Why do you have oligemic lung fields? Because there is decreased pulmonary blood flow. And you have an inconspicuous vascular pedicle. Look how small the vascular pedicle is. Okay, you have an inconspicuous vascular pedicle. So these are three things which I taught you on chest X-ray Epstein's. Cardiomegaly, oligemic lung fields, inconspicuous vascular pedicle. So again, based on this, PA banding is indicated in all except Epstein's anomaly. So it's a very simple thing. You need not even look at the other options. So you just imagine a condition which decreases blood flow. So if you have studied the X-ray of Epstein's, you automatically will mark Epstein's. Again, it requires a bit of knowledge. So again, CCTGA is known to be associated with increased pulmonary blood flow. Complete AV canal defect is a combination of ASD plus VSD, both shunting left to right. So you have an increase in pulmonary blood flow. Dilated cardiomyopathy is a bit confusing for me until I referred some articles which said that pulmonary banding could be used. Okay, so pulmonary banding could be used. You can see these reference articles. Again, you need not even go for all this. So just imagine pulmonary blood flow is to be decreased by giving a pulmonary band. So you cannot use it in a condition which already has decreased blood flow. What is the condition which already decreased blood flow? It is Epstein's anomaly. So, which trial in chronic coronary syndrome was a double-blinded study using a sham procedure? Asked in AIMS 20. Ischemia trial, Orbiter trial, Bari 2D and Courage trial. So again, it's a question which you can apparently leave if you don't know the answer. But let's try to guess the answer. So, trial in chronic coronary syndrome, double-blinded study using a sham procedure. Okay. So, sham is basically a false procedure. So, again, if you look at the options, it's very difficult to guess an answer. But if I were to give you the dates of the trial, okay, Ischemia 2020, Orbiter 2018, Bari 2D 2009, Courage 2007. Remember, it's a question asked in AIMS 20. So, if I give you the years in which the trial came out, automatically an intelligent student would guess that it's either ischemia trial or orbital trial. They straight away rule out both of these because nobody is going to ask you the mechanism of older trials. Okay, so the answer is either ischemia or orbiter trial. Now you can guess the answer, and the answer is orbiter trial. Okay, see, expecting an MD person to know the mechanism of each and every individual trial, it's a ridiculous proposition. But however, you can straight away, you should know that ischemia and orbiter, they are new trials. They are landmark trials, ischemia and orbiter landmark trials which actually change practice. So you should know the latest trials. But expecting them to know the mechanism is a bit difficult. So that's why I said you can straight away rule out two options, and once you rule out two options, now you can take a guess. The answer is orbiter trial. So in the orbiter trial, what they did was they took people with chronic stable angina. So 230 patients were taken with more than 70% lesion. They were single vessel diseases. Okay. So in one group, they took both groups to the cath lab. Both groups of patients were taken in the cath lab. In one group, they sedated the patient, put in a sheath and did the angioplasty. In the other group, they sedated the patient, put in a sheath and did not do anything. So again, both patients, the initial steps were the same. They put in a sheath, they sedated the patient, and they actually gave him headphones also, which playing music, so that they could not get a clue. So the patients were completely blinded. They were sedated, and on top of their ears, headphones were put playing music. So the patients had no idea what was being done. Again, in both groups of patients, control as well as the study group, arterial sheath was put. In one group, the angioplasty was done. In the other group, the angioplasty was not done. And this was how the orbiter trial was conducted. That's why he called a sham procedure. Okay, they acted as if they were conducting the procedure on the study control group. So we come to the next question. Hyperoxidation will improve SpO2 in. So asked in JIPMER 19. So again, you see a lot of complicated congenital heart disease, single ventricle, TAPVC, hypoplastic left heart, tricuspid atresia. So again, the regular student will sit and think about all the pathophysiology of all the individual conditions given here. The intelligent student will do something like this. Single ventricle falls under admixture physiology. TAPVC falls under admixture physiology. Tricuspid atresia falls under admixture physiology. HLHS is basically left heart obstruction. Supramitral ring, mitral atresia, aortic atresia, you can have coarctation of aorta. So basically left heart obstruction. So now if you think like this, straight away you can think that the answer is hypoplastic left heart. Straight away the answer is hypoplastic left heart. So instead of looking at each and every condition's pathophysiology, remember single ventricle, admixture, TAPVC, admixture, tricuspid atresia, admixture. Only one condition is a different group, is HLHS. Okay, so the answer is straight away HLHS, not much thinking required. So, see, HLHS is also PDA dependent. It is patent ductus arteriosus dependent. So, remember HLHS in utero is very well tolerated. The babies in fact have a higher birth weight than normal. Okay, it is when the baby is born, when the baby takes his first breath, you have increased oxygenation. The increased oxygen levels will cause the ductus to close. And it is when the ductus closes that the patient goes in for shock and pulmonary edema and all those. That is why hyperoxygenation is expected to worsen in HLHS. So remember, HLHS is a ductal dependent circulation. Systemic circulation depends on the patency of the ductus. In utero, HLHS is very well tolerated, your ductus patent. When the baby is born, the duct starts to constrict because of increased oxygen. Okay, that is why if you give more and more oxygen, the duct is going to close very fast and HLHS patient is going to crash. So again, not much thinking required. You can just see Three conditions have one physiology, one condition has another physiology. That's obviously the answer. So which variety of HCM carries best prognosis? Obstructive HCM in women, obstructive HCM in athlete, obstructive HCM in elderly, non-obstructive HCM. The same mechanism, only one condition is different, so it's non-obstructive HCM is the answer. So again asked in AIIMS 21. So this is the second question which I am giving you from AIIMS 21. Okay, so again the same mechanism. Obstructive HCM, non-obstructive HCM always has a better prognosis than obstructive HCM. The same rationale which we used for the last question. So balloon atrial septostomy is needed in all except asked in AIIMS 20, TAPVC, truncus, TGA and Epstein's. Again, lot of complicated congenital heart disease. So why do you do a balloon atrial septostomy? Okay, you do a balloon atrial septostomy to enlarge the atrial septal defect. So in conditions which have a very small ASD, you enlarge the ASD so as to promote free mixing of blood between LA and RA. So in which condition among this option do you need not have a free mixing of blood in the LA and RA? That's how you should think. A balloon atrial septostomy is used to increase the atrial septal defect so as to promote mixing of blood between LA and RA. Among these options, which condition does not require mixing of blood in the LA and RA? Now the answer is truncus arteriosus. Why? Truncus arteriosus is a common aorta as well as pulmonary artery trunk. There is a common aorta pulmonary artery trunk because there is failure of development of the aorta pulmonary septum. So in this you have free and complete mixing of blood from the pulmonary artery and aorta. And remember there is a mandatory perimembranous VSD also. So again you can see already there is a very good mixing of blood in the aorta and pulmonary artery. So you need not do a balloon atrial septostomy. A shunt at the atrial level is not required because there is an extensive mixing of blood at the great arterial level. This is how you should think. Straight away you can see the answer is truncus arteriosus. So I'll just rule out the other options. In TAPVC, the SVC drains into the RA, the IVC drains into the RA, your pulmonary vein drains into the RA. Again, the LA does not receive blood. So you have an atrial septal defect here, okay, through which blood reaches the LA. So the blood reaches the LA through the atrial septal defect. If the atrial septal defect is small, the patient can crash. At that time, you enlarge the atrial septal defect. We come for TGA. The classical indication for a balloon atrial septostomy is TGA with a small ASD or an inadequate ASD. So remember in TGA, you have two parallel circulations. You have the pulmonary circulation, the systemic circulation here. And you have either a communication at the atrial level, ventricular level or the great arterial level, a PDA for the patient to survive. Now, if this child has only an atrial communication and the atrial communication is small, the patient crashes. So, at this time, you enlarge the atrial communication. Remember, the classical indication for a BAS is TGA with a small ASD. And Epstein's, again, not frequently used in Epstein's. Epstein's, you have a large RA and a small RV. Okay. So, if you have sometimes a very small RV and very low pulmonary artery blood flow. So, in that case, remember, ASD in Epstein's is seen in 50% of cases. It is the ASD which maintains survival. So, in that cases, you have to enlarge the ASD. Again, all this explaining is not required. If you know that truncus arteriosus, there is a common arterial trunk, extensive mixing takes place in this arterial trunk, then straight away you get the answer as truncus arteriosus. So, again, this is how a balloon atrial septostomy is done. And the catheter is taken across the RA into the LA. And then a balloon is inflated and then you give a sudden tug so as to enlarge the atrial septum, atrial septal defect. Again, it can be done even in the bedside also in cases of emergency. So, LV SS devices contraindicated in, again, this is the third question in AIIMS 2021. Renal disease, metastatic cancer, pulmonary hypertension, RV failure. Again, pure logic, you can answer this question. The answer is metastatic cancer. See, LV SS device is a very complex procedure and it costs around 50 lakhs. So again, if the patient is anyway going to die due to a metastatic cancer, there is no point in putting an LV SS device. So again, remember, an LV SS device is a very complex procedure and a very expensive procedure. So if the patient is anyway going to die, there is no point in putting an LV SS device. So what about renal disease and liver failure? Remember, irreversible end organ damage is a contraindication. So if the patient has irreversible renal failure, irreversible liver disease, that is a contraindication. So renal disease is not a contraindication. In fact, you would have seen many dilated cardiomyopathy patients have cardiorenal syndrome. The moment the cardiac status becomes better, there is improved renal perfusion and the creatinine starts coming down. So irreversible renal disease is a contraindication, not pure renal disease. So metastatic cancer is a contraindication, cerebral damage, neurological deficit, unresolved psychosocial issues, coagulation disorders, heart valves, severe AR, bleeding disorders. All of these are contraindication. Again, the only thing you need to know is, you're putting such an expensive device. If the patient is going to die of some other cause, why put in the expensive device? And now you can straight away get the answer as metastatic cancer. So again, irreversible endocrine damage, contraindication. Metastatic cancer, contraindication. Again, cerebral damage, neurological deficit, unresolved, all those are contraindications. Coagulation disorder. Remember, you're doing a major surgery, it's an open heart surgery. If the patient has a coagulation disorder, you can never stop his bleeding. Mechanical heart valves, because now you have two prostheses. You have a mechanical heart, let's say you have a mechanical heart and you have a mechanical heart valve. So again, high risk for thrombosis. Okay, severe AR. Why? You're doing putting in an LVAD here. Okay, the moment the LVAD comes here and attaches to the aorta, if there is severe AR, whatever blood that enters here comes back into the LV. So there is no point. And finally, bleeding disorders. So we come to the next question asked in AIIMS 2021. So this is your fourth question, okay, which you can answer based on logic. So 35-year-old with dyspnea with the following chest X-ray with ejection systolic murmur in the left third intercostal space with a wide fixed split. Diagnosis is. So a chest X-ray is given, you have the clinical features given, and you are asked what is the diagnosis. So LTGA with VSD, DTGA with ASD, Epstein's and TAPVC. So here I am not even showing you the X-ray. Okay, so how can you guess? Remember, it's a 35-year-old. So automatically two options straight away go out. So an uncorrected TAPVC and uncorrected TGA with an ASD, the survival rate beyond 1 year is very miserable. Okay, it is dismal. So automatically you can straight away rule out two options. So even without looking at the X-ray, I can straight away rule out two options. Now it's either LTGA or Epstein's anomaly. So again, this is the X-ray which was given. So again, I told you, what do you see in Epstein's anomaly? You see an inconspicuous vascular pedicle. So what is the first thing you see here? A very wide mediastinum, a very wide vascular pedicle. So straight away, I can rule out Epstein's anomaly. The answer is LTGA with VSD. So I don't know how an LTGA with VSD X-ray looks, but straight away, even now I can straight away rule out these three options. Remember, I have finished my DM cardio. If I don't know what an LTGA X-ray looks, how are you going, how is the examiner expecting you to know how an LTGA with VSD X-ray looks? The examiner wants you to rule out the other options and answer the given question. So again, DTGA and TAPVC, they don't survive till 35 without interventions. DTGA with the options Epstein's. Again, Epstein's has an inconspicuous vascular pedicle. Here you have a very prominent vascular pedicle. And straight away the answer now is LTGA with VSD. So again, next question we come in. Again, this is the fifth question asked in here, which we can solve from AIIMS 2021. This is number 5. So 85-year-old found unconscious on the road. They have given you an ECG and asked you to find the diagnosis. So delta wave, beta wave, epsilon wave, Osborn wave. Here I am not even giving you the ECG. I am asking you to straight away find the answer. So 85-year-old found unconscious on the road. So is it delta, beta, epsilon or Osborn? So there's nothing like beta wave, so you can rule out this option. So 85-year-old, remember in AVRT, your accessory pathway conduction decreases with age. So it's not possible. It's at an age of 85, it's very, very rare to get a delta wave at age 85. So remember, your accessory pathway conduction decreases with age. If they want you to identify a delta wave, they'll give you something like a 25-year-old male, not an 85-year-old male. What about epsilon wave? See, and it indicates ARVD. Now, in an ARVD, remember, ARVD can present at any age. But usually, ARVD, the classical ARVD presents in youngsters. Okay, remember all your questions, 25-year-old footballer or an 18-year-old cricketer, something like that. They are all pretty much youngsters. For an ARVD to remain silent and then present at 85 is not possible. So the answer straight away is Osborn wave. And something like this was given as an ECG. You can see the Osborn waves here. It's part of a J-wave syndrome. You can see the prominent J-wave Osborn waves. See, this is why it mimics a STEMI. If you look at the differential diagnosis for ST elevation on the ECG, you can see Osborn wave is 1. So irrespective of the ECG, you can straight away find out the answer. So 85-year-old, delta wave is extremely uncommon in 85. Your accessory pathway undergoes age-related sclerosis and fibrosis. So as you age, your conduction through the accessory pathway decreases. Again, there's nothing called beta wave. Epsilon wave, typically when you think of ARVD, you think of young people, not an 85-year-old female. This is probably hypothermia. So this woman collapsed on the road, probably it was hypothermic, and that's why you got the Osborne wave. So you must treat her by rewarming this patient. So again, this is we have 5 questions from AIMS 2021. So again, onset of cyanosis at 25 years of age is consistent with all except. So the patient was acyanotic till 25. So which condition present with cyanosis at age 25? Again, the answer is straight away, you can see it is truncus arteriosus. Remember I told you what truncus arteriosus is. You have a common trunk. The aorta and the PA arise from a common trunk. There is extensive mixing of saturated and desaturated blood. This is an admixture physiology and is necessarily cyanotic at very early age. So again, remember the answer is straight away admixture of the truncus arteriosus. So remember, Epstein is one condition I told you can present at any age, right from infancy all the way to 90 years of age. Okay, ASD Eisenmenger, I told you, Eisenmengerization occurs in the 3rd or 4th decade of life. Please look at the Eisenmenger module. The only confusion for me was TOF, because TOF is one thing. If you have severe TOF, the severity of TOF depends on the degree of RVOT obstruction. So severe TOF presents in very early ages, during infancy. So why have they mentioned like this? I had no idea. But anyway, the answer is truncus arteriosus. So I looked up at articles. You have cyanotic spells in adults. So you can see cyanotic spells presenting in 75 years of age also. So again, these are rare cases. So again, but remember, if you see this clearly, you can utilize logic to find out that truncus arteriosus, which is an admixture physiology, has to present with cyanosis very early, not at 25. So now we come to the 6th question from AIMS 2021. So a person with history of syncope with a J point elevation in the infralateral leads more than 1 mm, treatment is all except. So here you are dealing with J-wave syndromes. And what are the 2 J-wave syndromes? They are early repolarization syndrome and Brugada. So remember, it is an ST elevation in the infralateral leads, so you can straight away rule out Brugada. So you are dealing with an early repolarization syndrome. So again, they have asked you the treatment. So again, let me ask you a question. Early repolarization pattern is seen in tachycardia or bradycardia? You know that early repolarization pattern is typically seen in bradycardic patients. So if you see an early repolarization syndrome, you make the patient walk up and down, increases heart rate. You take an ECG, the early repolarization pattern is abolished. So remember, tachycardia abolishes the early repolarization pattern, brady increases it. So all you need to know is this statement. So that's how, if you have done your MD, you would have automatically seen lot of early repolarization patterns. And you know that early repolarization pattern is typically seen in bradycardic patients, the typical fish hook and the typical concave ST segment elevation. All of this is seen in bradycardic patients. If it allows a tachycardia, that is abolished. Now, if you know this, you know that esmolol cannot be given. Why? Because esmolol is going to increase your early repolarization pattern. Bradycardia increases your early repolarization pattern, tachycardia abolishes it. So again, the answer is straight away IV esmolol. So again, isoprenaline increases the heart rate, so that can be given. Cilastazol and quinidine also can be given. Please refer that out. Again, you need not know this. You just need to know that tachycardia abolishes the early repolarization pattern, bradycardia increases it. Your typical early repolarization is seen in bradycardic patients. So the lower the heart rate, that is when you see early repolarization pattern. So again, this is the question. You have the ST elevations here. This is your typical fish hook. Okay. Fish hook. Okay, we just seen an early repulsion pattern. Remember, this is also bradycardia. This heart rate is around 55 per minute. So typically seen in bradycardia. You make this patient walk up and down or you give atropine. This entire early repulsion pattern will be abolished. So again, the different types. I've already told you this. You can read this. So type 3 is associated with VTVEF storms. So it is global, infralateral, right precaudal leads. Type 4 ERP by some authors is called as Brugada. Some people call this separately. So some authors say type 4 is Brugada. Some people say that it is a separate syndrome. So again, whatever is fine. So again, we come to the 7th question asked in AIMS 2021. Most likely cause of syncope in adult. So PCO2 of 10, PO2 of 65, heart rate of 50, RBS of 50. So again, nothing very sensational about this question. See, heart rate of 50, even normal individuals can have a heart rate of 50. At a heart rate of 50, no one is expected to have a syncope. PO2 of 65, hypoxic patients. So how do you see hypoxic patients? Hypoxic patients are agitated, they are hyper, they are struggling for breath. They don't present with syncope. Okay. Then now we have two options, PCO2 of 10 and RBS of 50. Remember, hypoglycemia does not cause syncope. Please remember that. Hypoglycemia does not cause syncope. Okay, you should never mention a statement called hypoglycemia causes syncope. Okay, the typical what is the definition of syncope? It is transient loss of consciousness, loss of postural tone. That is why the patient falls down. So, transient loss of consciousness, loss of postural tone, full recovery within few minutes. So, there is a full recovery within few minutes. The moment he assumes a lying down posture, he falls down, assumes a lying down posture, the blood flow to the brain improves and he wakes up. Now, you can give some allowance for elderly people because they have the cerebral and they have vertebral and carotid vascular disease. So, some allowance can be given for elderly population. So, remember it's transient LOC. I'll just write this once more. You have transient LOC. You have loss of postural tone, full recovery without focal neurological deficit or without postictal state, whatever. They should be completely normal. Okay, within few minutes. Remember, elderly, because they have carotid and vertebral disease, some allowance can be given. Okay, no interventions should be done. You should not give a DC shock, you should not give him dextrose, nothing should be done. So, transient loss of consciousness, loss of postural tone, full recovery, no intervention should be done. All of this is required for a definition of syncope to be satisfied. So, if a patient presents to you with hypoglycemia, you have to give the patient dextrose for the patient to improve. Otherwise, he is not going to improve. So, remember, hypoglycemia does not cause syncope. So, again, all these three options are out. The answer is PCO2 of less than 10. So, it's pretty logical. If you have worked in your wards, you would have seen many young females come to the casualty. Suppose they have a death of the family, they start hyperventilating. They keep on hyperventilating. There is carbon dioxide washout. There is metabolic alkalosis, hypocalcemia. So, you have hyperventilation, you have metabolic alkalosis, and you have hypocalcemia. That is why they present with tetany, perioral numbness, all those. The typical patient you see in your casualty. So, young female, they keep on hyperventilating because of anxiety. So, death in the family, going for exams. So, they hyperventilate. So, that results in metabolic alkalosis that can cause hypocalcemia. This hyperventilation also causes carbon dioxide washout. And this can cause cerebral vasoconstriction. And this can cause syncope. So, you would have seen a lot of people, even in your movies. So, somebody says about that your father has died and ultimately they start hyperventilating and fall down and have a syncope. So, again, if you receive a bad news, people develop syncope. One of the reasons is this. Because when you receive bad news, you become anxious, you start hyperventilating, carbon dioxide is washed out, there is cerebral vasoconstriction and the patient goes in for syncope. When they have loss of consciousness, your respiration returns back to normal and they awaken subsequently. So remember, standard case which you see in your casualty. Bad news, hyperventilation, metabolic alkalosis, hypocalcemia. Hyperventilation causes carbon dioxide washout, cerebral vasoconstriction, loss of consciousness. So again, the answer is PCO2. So now we come to the 8th question asked in AIMS 2021. So best time for fetal echo during pregnancy: 6 to 8 week, 8 to 12th week, 16 to 20th week, and 24 to 20th week. So again, pretty logical. Why do you do a fetal echo? You do a fetal echo so as to find out some cardiac abnormalities in the fetus so that you can offer abortion to the mother. Okay, so if the fetus has a gross cardiac anomaly, abortion can be done. So remember, 6 to 12 weeks is your period of organogenesis. So again, there is no point in doing a fetal echo at this time. Okay, 20 weeks. Okay, is the time limit for abortion in India. Again, now the judgment has come to make it 24 weeks in rare circumstances, but usually what we study is 20 weeks. So there's no point in doing it after 20 weeks also, because you cannot abort the fetus. So this is also out. So the answer straight away is 16 to 20th week. Okay, so 6 to 12 week is a period of organogenesis. You don't do it at that time. You should not do it after 20 weeks because again abortion is out of the picture. So your ideal time is 16 to 20 weeks. So remember, the time limit of abortion has been increased. Now it can be done up to 24 weeks, provided again certain special circumstances has to be there. So again, you don't know this, you just use your logic, you know that you have the answer 16 to 20 weeks. So fetal echo is done at 16 weeks. Fetal echo is the probe is placed on the abdomen of the mother. Okay. Transvaginal echo is done at 13 to 14 weeks. So if you do a TVS, you can do it around 13 to 14 weeks. So now we come to the 9th question asked in AIMS 2021. Which of the following is abnormal in athletes? So ectopics at a heart rate of 70, T-wave inversion V1 to V3, T-wave inversion at V4 to V6, junctional rhythm. Again, remember, ectopics is a pretty normal phenomenon. You do a ECG for about 10 people, around 2 will have ectopics. So again, this is a normal phenomenon, so this we expect. T-wave inversion V1 to V3, again normal phenomenon. I told you, T-wave inversions are not a sign for ischemia. Okay, T-wave inversions can be seen in numerous conditions, both pathological as well as non-pathological. Remember, females can have T-wave inversions from V1 to V3. You can have a persistent juvenile pattern, lot of things. So even this is also a normal phenomenon. So T-wave inversion at V4 to V6 or junctional rhythm. So remember, what is an athlete's heart? Athletes have an increase in vagal tone. Okay, athletes exercise a lot, they have an increase in vagal tone. This causes bradycardia. And this bradycardia can sometimes have a junctional rhythm. You have an increased vagal tone and you can have a junctional rhythm as a result. You get junctional rhythm in MI. Why? Because there's an increased vagal tone. Similarly, athletes also, due to their constant exercise, can have an increased vagal tone. They can develop sinus bradycardia, they can develop first degree heart blocks, they can develop second degree AV blocks, they can even develop junctional rhythms. The answer is T-wave inversion V4 to V6. Okay. So remember, there's a differentiating point between athlete's heart and HOCM. There's a table which I've already taught you on how to differentiate between HOCM and athlete's heart. Remember, T-wave inversion in V4 to V6 in the presence of LVH indicates what? It indicates LV strain. Okay, that's why we say as LVH with strain pattern. So HOCM, you can have LVH with strain pattern. Athlete's heart is a hypernormal heart or a very good heart. This should not go in for a strain pattern. So straight away you can see the answer is T-wave inversion V4 to V6. So remember, athlete's heart is a super normal heart. It should not have a LV strain. You can have LVH, but there should be no LV strain. So straight away the answer is T-wave inversion V4 to V6. So again, we come to the next question. 10th question asked in AIMS 2021. So in patients with CKD and on maintenance hemodialysis, this patient has a multi-vessel CAD and you have inducible myocardial ischemia on stress. What is the management of choice? So patient is a CKD patient on hemodialysis. You have done an angio, you have found there is multi-vessel CAD. You have also proven there is myocardial ischemia. What do you do? Again, this is an absolutely idiotic question. Okay. Again, this is not what we practice in the real world. But again, the answer they expect is CABG. The answer they expect is CABG. Okay, because again, why? Okay, remember this is a CKD patient. He has multi-vessel disease. So if you do a PCI for this patient is a high risk for contrast-induced nephropathy and renal failure. Okay, so again, more and more amount of dye has to be used. So that's why you prefer CABG. Okay, again, remember as a general dictum. Okay, this is not a hardcore rule. As a general dictum, diabetic patients, LVEF, the LVEF is low, or LV dysfunction patients, CKD patients. Okay, all of this CABG is superior to PCI. So in diabetic patients, LV dysfunction patients, CKD patients, multi-vessel disease, complex coronary anatomy, all of this, again, CABG is superior. So diabetic patients, low EF patients, CKD patients, when you have multi-vessel disease, complex coronary artery disease, all those CABG is preferred as a general dictum. See, how this? Why is this an idiotic question? See, again, you're not told anything about the vascular anatomy. You can have 3 very discrete lesions. So the LAD might have a discrete lesion of 70%. The RCA might have a discrete lesion of 80%. The LCX might have a discrete lesion of 70%. So again, easily doable by PCI. So again, this patient might be easily doable by PCI. Again, in that case, you can do a PCI in this patient. Okay. In another case, all 3 vessels might have diffuse disease. Okay. So the entire LAD might be diffusely diseased. Okay. In that case, you cannot do a PCI, you cannot do a CABG, because when you do a CABG, you are placing a graft distally. So the lemma is taken and put distally on the LAD. So if this anastomotic site has disease, then you cannot do a CABG for this patient. So again, you're not taught anything about the anatomy. So you cannot answer this question. Again, I answer this question based on CABG because generally diabetics, low LVEF patients, CKD patients, multi-vessel disease, generally you prefer CABG. Again, I told you, generally. Suppose this is a 90-year-old patient. Will you subject this patient to a bypass? No. Most of us will probably ask this patient to take medical management. This 90-year-old patient might not survive the stress of CABG. So again, patient context is very important. That's why I said this is an idiotic question. But however, with the available evidence or the available options, I would say CABG is the answer. So this is number 10. What is the type of neuromuscular disease? So identify the type of neuromuscular disease based upon this ECG. So again, this is a question I have framed. So I would like you to pause this video and analyze this and tell me what type of neuromuscular disease you can identify based upon this ECG. So again, when you ponder about this is the next question. Where do you get a tall R wave in lead V1? So this is all except. So tall R wave in lead V1 is seen in all except WPW, DMD, chest leads reversal or left posterior fascicular block. The answer is LPFP. This is a standard exam question. It has been asked for years together. So where do you get a tall R wave in lead 1? Again, RBB, yes. The RBB pattern is an RS R prime pattern. RVH, yes. I've told you there are 3 patterns. You can get a QR pattern in V1. You can get a monophasic R in V1. Or you can get an R by S greater than 1 in V1. So a QR pattern signifies suprasystemic pressures. Monomorphic R signifies systemic pressures and an R by S signifies subsystemic pressures. So when you get a QR pattern in lead 1, indicates that the pulmonary circulation has a higher pressure than the systemic circulation. When you get a monomorphic R in V1, it indicates that the pulmonary circulation and systemic circulations have approximately equal pressures. R by S more than 1 indicates there is subsystemic pressures. So WPW, I've told you there are 2 types of WPW syndrome, left and right side accessory pathways, that you can have a tall R wave in lead V1. Posterior wall MI, again, nothing to be said. You all know that posterior wall MI has a dominant R wave in lead V1. HCM, again, if the HCM involves a posterior wall, you can have a tall R wave in lead 1. The same mechanism applies here. The posterior wall, when you have a hypertrophy of the posterior wall, you can have a dominant R wave in V1. Duchenne muscular dystrophy. So why do you get tall R wave in lead 1 in Duchenne muscular dystrophy? The same thing applies in Becker's also. Remember, Duchenne and Becker fall on a spectrum. So remember, you have postrobasal and postrolateral fibrosis. So in Duchenne muscular dystrophy, you have the posterior basal wall as well as the postrolateral wall going in for fibrosis. The same thing applies as to what you get in posterior wall MI. That's why you get a tall R wave. So in tall R wave is seen in lead V1 in posterior wall MI. The same mechanism is seen in a Duchenne muscular dystrophy. You get postrobasal and postrolateral fibrosis. Again, dextrocardia, misplaced precord leads and a small percentage of normal individuals. So again, these are your cause of tall R wave in lead 1, standard question. So right bundle branch block, right ventricular hypertrophy, Wolff-Parkinson-White, posterior wall MI, hypertrophic cardiomyopathy in which you have a posterior wall hypertrophy, Duchenne muscular and Becker's muscular dystrophy because of postrolateral or postrobasal fibrosis, dextrocardia, misplaced precord leads and normal individuals. So again, with this knowledge, if I ask you this question now, identify the type of neuromuscular disease, straight away you will see a tall R wave in lead V1, straight away you will say it's either DMD or BMD. So again, based upon your knowledge of another standard question, you can answer this question. So identify the type of neuromuscular disease, straight away you will see this and you will say it's a Duchenne or a Becker's muscular dystrophy. So again, you should know the certain clinical features of neuromuscular diseases. Okay. Remember DMD and BMD, they generally present with a dilated cardiomyopathy. Okay, you have posterobasal and posterolateral fibrosis, you have a tall R wave in lead 1. So DMD and BMD generally presents with dilated cardiomyopathy. BMD obviously is going to have a less severity than a Duchenne muscular dystrophy. So DCM is your characteristic presentation. What about myotonic dystrophy? Myotonic dystrophy generally involves your conducting system. Okay, this can present with bradyarrhythmias as well as tachyarrhythmias. Bradyarrhythmia is more common than tachyarrhythmias. So you can have various forms of bradyarrhythmias. You can have complete heart block, first degree heart block, second degree heart block, all those. You can have atrial fibrillation, you can have atrial flutters, you can have bundle branch re-entry VT, all those sorts of things. So remember, DMD and BMD mainly present as a dilated cardiomyopathy. Myotonic dystrophy mainly presents as a conducting system disorder. So remember, it's bradyarrhythmia more common than tachyarrhythmias. All sorts of bradyarrhythmias, including complete heart block, have been discovered. You can have a sinus bradycardia, you can have first degree, second degree, third degree AV block. Tachyarrhythmias, you can have atrial fibrillation, flutters, BV, bundle branch re-entry VTs. Okay, so Emery-Dreyfus presents as a combination of DCM plus conducting system abnormalities. So again, Emery-Dreyfus, remember, combination of DCM plus conducting system abnormalities. Okay, the limb girdle generally presents as dilated cardiomyopathy. And facioscapulohumeral dystrophy usually has no significant cardiac involvement. Friedreich's ataxia, I have told you, classically HCM-like presentation. Okay, so again you should know this. Remember DMD and BMD, remember they are due to a deficiency in dystrophin or some problem with the dystrophin gene. And again, you get myopathy with a dystrophin gene. So you can get skeletal myopathy and you can get cardiac myopathy also. So DMD has more deficiency of dystrophin, you get dilated cardiomyopathy earlier and more frequently. Myotonic dystrophy usually involves the conducting system of the heart. Brady more common than tachyarrhythmias. Emery-Dreyfus, a combination of both dilated cardiomyopathy and conduction system disorder. Limb girdle mainly as DCM. And very important, this can be asked on all except facioscapulohumeral dystrophy has usually no significant cardiac involvement. Friedreich's ataxia is HCM. So again, predilection for conduction tissue seen in Aston Jipmer, the answer is myotonic dystrophy. Again, I told you, myotonic dystrophy has a predilection. It involves the conducting system, bradyarrhythmias and tachyarrhythmias. So again, straight away you can see the answer is myotonic dystrophy. So least chance of thromboembolism is with, so asked in AIMS 2020, chicken wing LA blood flow of less than 20 centimeters per second, spontaneous echo contrast in LA thrombus. Again, utilizing logic. If you have a LA thrombus, you obviously have a higher risk for thromboembolism. So this is out. Okay, spontaneous echo contrast in LA. Again, remember, the spontaneous echo contrast is generally a precursor to LA thrombus. So if you see that, you have a higher chance for thromboembolism. Now again, you have two options, chicken wing LA and LA blood flow of less than 20 per second. If you look at these two options, which option are you likely to mark? So again, it's written that the LA blood flow is less than 20 centimeters per second. So obviously, even if you don't know what a normal value is, you'll obviously think that this can cause thromboembolism, and you will mark chicken wing LA as the answer. So again, utilizing logic. So LA thrombus, high chance. Spontaneous echo contrast in the LA is a precursor to LA thrombus. So if that is there, again, it can cause thromboembolism. LA blood flow of less than 20 centimeters per second. Again, you don't know what is normal, but you can practically guess that this is probably a slow flow. So the answer has to be chicken wing LA. So the answer is chicken wing LA, left atrial appendage. So risk of thromboembolism, you have different types of LA appendage. You have the cauliflower, you have the this is the cauliflower, you have the windsock, you have the cactus, and you have the chicken wing. Again, everything looks the same to me. It's very difficult to say that this looks like a cauliflower and this looks like a cactus. But again, these are your four types: cauliflower, windsock, cactus, and chicken wing. Cauliflower is most commonly associated with the thromboembolism. Chicken wing is least commonly associated with thromboembolism. I want you to remember both of this. Cauliflower is most commonly associated with thromboembolism. Chicken wing is least commonly associated with thromboembolism. Again, this is your LA appendage. You can see a thrombus here. Okay, what we do is we place a Doppler here and look at your LA appendage velocity. So again, the LA appendage velocity should normally be more than 40 centimeters per second. If it is less than 40, probably there is a chance for thromboembolism. So basically indicates that there is very good blood flow into the LA. When you have very good blood flow in the LA, there is less chance for stasis. If the LA velocity is low, there is sluggish flow in the LA, more chance for thrombosis. Again, you can utilize logic and try to guess that the answer is chicken wing LA. So, which congenital heart disease does not have cardiomegaly? So, which congenital heart disease does not have cardiomegaly? Asked in AIMS 2020. So, again, lot of complicated options. DORV, VSTPS, tricuspid atresia, VSTPS, pulmonary atresia, VSTPS, Epstein's anomaly. So, again, lot of complicated congenital heart diseases are given here. How can you guess this? So, again, very difficult. But again, utilize your logic. I told you Epstein's has the largest hearts. Your largest hearts are seen in Epstein's anomaly. Okay. Tricuspid atresia, I told you, has LV type of cardiomegaly. Okay. You have LV type of cardiomegaly, tricuspid atresia. And what is the closest differential diagnosis for tricuspid atresia? Even if you look at the module, please look at it. I've marked it here. I've told you that the closest differential diagnosis for tricuspid atresia is pulmonary atresia with intact IVS. Okay. In both conditions, you will have pulmonary oligemia, you will have LV dominance, and you will have a cyanosis. So, I will even written the reference of what I have told you here. So, I remember tricuspid atresia and pulmonary atresia with intact IVS are essentially similar conditions, similar physiologically. In both conditions, you will have pulmonary oligemia. In both conditions, you will have LV dominance. In both conditions, you will have cyanosis. The way you differentiate in your exam hall is you take an ECG, this is at a DM level, okay, not at an MD level. Pulmonary atresia with intact IVS septum, you have normal or right axis deviation, and tricuspid atresia, classically you have left axis deviation. Remember, both of these conditions are similar, and utilizing this, you can guess the answer to be DORV VSTPS. So, is there any other way you can come to this answer? There is actually. So, which congenital heart disease does not have cardiomegaly? So, let me ask you this question first. Identify the congenital heart disease associated with this condition. So, straight away you will say this is a boot-shaped heart, and the answer is you have the boot-shaped heart. You have RV hypertrophy here. You have a dilated aorta here. This is the boot-shaped heart or core and sabot. Turkish boot. Okay, it's a boot-shaped heart or core and sabot. You would straight away say this is TOF. Okay, even if you see this X-ray, again this is a spotter for you, you will straight away say this is TOF. Does cardiomegaly occur in TOF? You know, cardiomegaly does not occur in TOF. Okay, you can even read Perloff will tell you. Remember, there is RV hypertrophy in TOF. Okay, and remember, it is mild RVH. Severe RVH is never seen in TOF. Okay, at the most, it is mild RVH, and that is why cardiomegaly is not seen in TOF. Okay, so TOF does not have cardiomegaly. So another way of answering this question is, which congenital heart disease does not have cardiomegaly? You have conditions of TOF physiology. Okay, which condition is a TOF physiology among this? You can see the answer is DORV VSTPS. So if you know that TOF does not have cardiomegaly, and if you know the TOF physiology conditions, okay, you can straight away mark the answer as DORV VSTPS. Again, two different methods of coming to the same answer. Okay, one was Epstein as a large heart, tricuspid atresia as LV cardiomegaly, and remember tricuspid atresia and pulmonary atresia, the intact IVS are physiologically similar, and the remaining option is DORV VSTPS. The other way is look at the TOF physiology. DORV VSTPS is TOF physiology. TOF does not have cardiomegaly, hence this does not have a cardiomegaly also. So two different ways. Again, you should have background knowledge. You cannot straight away know nothing on congenital heart disease and answer this question. You should have your basic knowledge of congenital heart disease. With that, you can answer this question. So a bit more. When I say pulmonary atresia with intact IVS, okay, actually there are two different types of pulmonary atresia with intact IVS. Okay, you have the more common one where the RV is small and the LV is dominant. This is what mimics tricuspid atresia. You have the less common one where the RV is RARV is grossly dilated, and this mimics Epstein's anomaly. Okay, so just an information for you. Pulmonary atresia with intact IVS, there are two types. You have the more common one where the RV is small and atrophic and the LV is dominant. That is why this mimics a tricuspid atresia. The other one is you have a less common variety where the RV is dilated, the RARV is dilated, and this mimics an Epstein's anomaly, and this again has the largest hearts or wall-to-wall hearts. So again, if you see a large heart or a wall-to-wall heart, you can have Epstein's anomaly as well as the rarer variety of pulmonary atresia with intact IVS. Okay, this is just an information which I wanted you to know. You see a very large wall-to-wall heart, you can have Epstein's as well as the rarer variety of pulmonary atresia with intact IVS. Okay. So all of the following are associated with gross cardiomegaly in infancy except Chitra 19. Again, remember Chitra, you have to know in and everything on congenital heart disease. They ask you very standard questions. You cannot help it. If you want to get in Chitra, your knowledge on congenital heart disease should be very strong. So again, pulmonary atresia with intact IVS, critical PS, Epstein's and TGA. Okay. So the answer here is, so pulmonary atresia with intact IVS, you have the rarer variety, you have the more common variety can have an LV type of cardiomegaly. The less common variety can have an RV type of cardiomegaly. And this can be huge, can be wall to wall mimicking an Epstein's anomaly. That's why I said this before. Epstein's anomaly, I told you the largest hearts generally are Epstein's hearts as well as the rarer variety of pulmonary atresia with intact IVS. Okay, TGA again can have cardiomegaly. Okay, not a very severe cardiomegaly, a moderate size cardiomegaly. The answer is critical PS. Okay, critical PS generally does not have a large cardiomegaly. Again, it requires you to have a bit of knowledge, but this is just to emphasize the point which I told you on the previous slide. So pulmonary atresia and Epstein's anomaly, huge hearts. So there can be wall-to-wall type of hearts. TJ can have a moderate degree of cardiomegaly, but remember the answer is critical PS. Okay, critical PS does not have cardiomegaly. Okay, this is mentioned even in Perloff. So critical PS does not have cardiomegaly. Okay, mentioned in Perloff. So 20-year-old female with dyspnea, likely diagnosis. So you have a lot of AS, MS, PS, TS. Again, what does this ECG show? You can see right axis deviation. You can see a monomorphic R in lead V1. So RVH. So RVH, you can see strain pattern. So you can see RVH with strain with right axis deviation. Okay, so it's all, the ECG is all RV. So straight away you can rule out AS, you can rule out TS. Okay, TS does not involve the RA, there is RA enlargement. So TS is also ruled out. The answer is either MS or PS. So is there LA enlargement on the ECG? There is no LA enlargement on the ECG. The answer is PS. Okay. So again, the ECG shows RVH with strain with right axis deviation. AS is out. TS does not involve the RV, so that is out. So it's either MS or PS. There is no evidence of left atrial enlargement on the ECG. MS presents as LAE plus RAE plus RVH. This is your standard combination for MS. If you see LAE plus RAE plus RVH in a young female, always think of myelostenosis. Okay. So this is your RVH. You can see there is a monomorphic R in V1. This indicates systemic pressures. If there is a QR pattern, it indicates suprasystemic pressures. This is your QR pattern. QR pattern. This is suprasystemic pressures. The classical Q. See the small Q here, this is enough. QR pattern. Here there is no Q. So 20-year-old boy, severe PS, ECG shows R of 22 mm in V1. RV systolic pressure is. So again, this is asked in JIPMER. So they are giving you that the R wave in lead V1 is 22 mm. They are expecting you to find the RV systolic pressure. Again, you need to know this particular formula. The RV SP is 5 times the R in lead V1. So RV SP is equal to 5 R in V1. Okay, so the answer is RV SP is equal to 5 into 22, which is 110 mm. Again, very difficult. I did not know this. So when I saw this question, I went and back referred. So they are expecting you to know that how to calculate the RV pressure based upon your R wave in lead V1. The answer is 5 into R wave in V1. So there's another formula here. This is apparently a simpler formula. That's why I chose it. So 60-year-old female, orthopnea, dyspnea on exertion, D dimers are normal, BNP 78, normal is less than 100. Reason for the above finding asked in NEET. So probably this is a HFpEF case. Okay, so 60-year-old female, orthopnea, dyspnea on exertion. So D dimer is normal, so pulmonary embolism is straight away ruled out. BNP is 78. So they are asking you why the BNP is lower than normal. So they are giving you something like a HFpEF and asking you, the patient is in heart failure, why is the BNP normal? So like I told you, causes of low BNP. One is obesity. So remember, fat cells metabolize BNP. So the more fat cells you have, the more likely that you are to get a low BNP. Number 2 is early heart failure. So less than 1 hour. So it takes time for your BNP to start elevating. So early heart failure, you can have a pseudo low BNP. Number 3 is CCP and cardiac tamponade. So chronic constrictive pericarditis and cardiac tamponade. So why do you get ANP and BNP elevation? It's because the atria as well as ventricle is dilated or stretched out. Okay, because of pressures or volumes. So dilation of the atria, dilation of the ventricle, this is what produces an elevated ANP and BNP. In constrictive pericarditis, the heart is surrounded by a rock-like calcific pericardium. It prevents dilation. In cardiac tamponade, the heart is surrounded by a fluid-filled pericardium. Again, that strangulates the heart. It prevents dilation. So because the dilation is prevented, you get lower than expected levels. So now obesity, fat cells metabolize BNP. So more the number of fat cells, the lower your BNP is. Early heart failure, it takes time for BNP elevated. CCP and cardiac tamponade, either the rock-like calcific pericardium or the fluid-filled pericardium prevents the atria and ventricle from stretching. So the answer is BMI more than 38, obesity. So D dimer not elevated to expected levels. The answer is obesity, early heart failure, constrictive pericarditis or tamponade. So I just wanted to take this opportunity to say something. So in every patient, the LV-EDP is equal to the LA pressure, which is equal to the pulmonary capillary wedge pressure. You can even extend that to equal the pulmonary artery end diastolic pressure. So LV-EDP is equal to LA pressure, which is equal to the pulmonary capillary wedge pressure, which is equal to the pulmonary artery end diastolic pressure. So remember, when the LV-EDP increases due to some cause, for example, the patient develops an LV failure or MI or diastolic dysfunction or AS with failure. Suppose the LV-EDP increases, the LA pressure increases to compensate, to maintain LV filling. So high LV-EDP, the LA pressure has to increase to maintain LV filling. Similarly, a pulmonary capillary wedge pressure has to increase to maintain LA filling. And when the pulmonary capillary wedge pressure increases, you can have dyspnea on exertion. There is exudation of fluid into the lungs. You can have dyspnea on exertion, function class 1, 2, 3 or 4 depending on the degree of elevation of pulmonary capillary wedge pressure. You can have orthopnea, you can have PND. Okay, so this is how it is. So LVDP increases, whatever the cause, LA pressure increases, pulmonary capillary wedge pressure increases. Similarly, and pulmonary artery end diastolic pressure increases. Because you have increase in PCWP, there's going to be exudation of fluid and varying degrees of dyspnea, orthopnea and pulmonary edema. So when you think dyspnea on exertion, when you think heart failure, you think of elevated LA pressure. So this elevated LA pressure can be due to several causes. Can be due to AS or AR with LV dysfunction. Can be due to LV dysfunction. So heart failure. So your left ventricle is failed due to MI or whatever. So remember, AS or AR per se does not produce elevation of LA pressures. Okay, the LV has to fail. So AS or AR with LV dysfunction. LV dysfunction due to any cause. It can be mitral stenosis. It can be MR with LV dysfunction. Okay, or even acute MR. So in MR, chronic severe MR does not produce elevation of LA pressures. The LA is going to dilate to huge proportions, thereby the LA pressure falls. So either there should be chronic severe MR with LV dysfunction, then only the LA pressure rises, or acute severe MR. Okay, so whatever the cause, you think, when you think pulmonary edema, when you think dyspnea on exertion, you think elevated LA pressures. What can cause elevated LA pressures? And for treatment, how do I decrease the LA pressures? This is what you should think of. So EF less than 20%, pulmonary edema least common in asked names ASD, VSD, PD or TGA. Automatically the answer is ASD. I told you, when you think pulmonary edema, dyspnea on exertion, heart failure, you think elevated LA pressures. If you have an ASD, the moment the LA pressure increases, okay, there is going to be shunting of blood into the RA and RV. So the moment the LA pressure increases, the LA pressure comes down because there is shunting of blood. So that's why I said, when you think of pulmonary edema, think elevated LA pressures. So increase in LA pressures, that causes cardiogenic pulmonary edema. If you have an ASD, the increase in LA pressure is prevented. Cephalization seen in all except. Similar question. So the answer is ASD. So there are lots of X-ray findings typically described in MS, true for any heart failure. So you can have cephalization, or you can have curly A, B, C lines. Okay, you can have fluffy opacities, you can have bat wing appearance. All of these are basically first described in mitral stenosis, is applicable for any heart failure. Because there is an ASD, this does not come into play. The same rationale what I've explained prior. So ASD with left to right shunt is seen in all except. So asked in AIMS. So again, it's all except. So they're looking for an ASD which shunts right to left. Again, the same mechanism what I've told you before. The answer is TAPVC. Okay, remember, SVC drains here, IVC drains here, pulmonary veins drain here. If the blood has to reach the LA, okay, it reaches through the mandatory ASD. An ASD is mandatory. There is a right to left shunt. So because there is no blood flow into the LA from any of the pulmonary veins, the SVC, the IVC, the pulmonary veins all drain into the RA. There is a mandatory ASD for the patient to survive, and it's through that the blood reaches the LA. So that's why they have a mandatory right to left shunt. Okay, nothing to explain here. So answer is TAPVC. So this is your bald LA. What we say is the LA is bald in the echocardiogram. SVC drains here, IVC drains here, pulmonary veins drain here, and as a result, if the patient has to survive, the ASD should be mandatory. So 8-year-old girl with easy fatigability, exertional pre-syncope, ESM at the base, asked in AIMS. Again, what does this X-ray show? The X-ray shows dilated pulmonary artery. Again, you can see here. Okay, why is this the pulmonary artery and not the left atrial appendage? Trace the bronchus, left bronchus. The part above the left bronchus is the pulmonary artery. The part below the left bronchus is the LA appendage. So this is above the left bronchus. The pulmonary artery is dilated. You have a right atrial enlargement. Okay. So if you have the right atrial enlargement extending more than 3 intercostal spaces, the right atrium exceeds more than 3 intercostal spaces, or if you divide the right half of the chest into 3, if it crosses into the beyond 1/3, you call it right atrial enlargement. So in this case, it extends beyond 3 intercostal spaces, 1, 2 and 3, there is right atrial enlargement, and this probably is also a right ventricular enlargement also. So RAE, RVH, dilated PA, again all right sided events. So again AS is ruled out. There is an ejection systolic murmur at the base, so MS is ruled out. MDM at the apex is not there. MS is ruled out. MR is ruled out. Why? There is no pansystolic murmur at the apex, so that is also ruled out. The answer is PS. It's all RA. RA enlargement, RV enlargement, dilated pulmonary artery. Everything is PS. Why do you get a dilated PA in PS? So PS, there is decreased pulmonary blood flow. So why do you get a dilated pulmonary artery? It is because of a phenomenon called post-stenotic dilation. So RAE, RVH, dilated PA due to a post-stenotic dilation. We come to the 11th question, which I think is can be analyzed and answered in AIMS 2021. Dilated coronary sinus is seen in all except unroof CS, LSVC, TAPVC or LV dysfunction. Again, let's utilize logic. It's a bit more difficult when compared to the other ones, but this can also be answered based on logic. So what is coronary sinus? It is essentially the vein of the heart. When does a vein dilate? One, if you have the distal compression. So if you have distal compression. So if you have a vein like this, if I compress distally, the vein is going to dilate. Another way is if there is increased venous flow. So if there is more flow, a vein here will dilate. So either distal compression or either there is increase in venous inflow. So let's look at the unroof coronary sinus. The coronary sinus lies along the posterior wall of LA. So if there is holes in the posterior wall of LA, there is communication between the LA blood and the coronary sinus blood. So there is left to right shunt. Okay, through the holes in the posterior wall of LA, there is left to right shunt. Blood from the LA enters in the coronary sinus. Again, coronary sinus receives more blood, it can be dilated. For it is frequently the unroofed coronary sinus is associated with an LSVC. So normally you have only a right SVC. The LSVC is due to the failure of left anterior cardinal vein to obliterate. Again, this is an MCQ for you. Normally only everyone has a right SVC. There is no LSVC. The left SVC is due to the failure of the left anterior cardinal vein to obliterate. So because of this, the unroofed coronary sinus is frequently associated with an LSVC. The LSVC drains 20% of blood from left half of head and neck and left upper limb. So left half of head and neck and left upper limb, 20% of blood is drained by the LSVC, and this opens into the coronary sinus. So again, you have an increase in coronary sinus blood flow. This can cause coronary sinus dilation. So many MCQs. So unroofed coronary sinus is basically have holes in the posterior wall of LA. There is left to right shunt. It's a type of ASD. This increases the coronary sinus blood flow. The unroofed coronary sinus is frequently associated with an LSVC, which drains blood from the 20% of blood from the left half of head and neck and left upper limb. So LSVC is due to failure of left anterior cardinal vein to obliterate. So again, both of this cause coronary sinus dilation. This is also important. Coronary sinus dilation from left horn of sinus venosus. This has also been asked. So again, unroofed coronary sinus, LSVC, increase in coronary sinus blood flow. Now, what about TAPVC? There are three types of TAPVC. One is a supracardiac TAPVC, one is a cardiac TAPVC, one is an infracardiac TAPVC. In types of cardiac TAPVC, the pulmonary veins open up into the coronary sinus. So when you have a cardiac TAPVC, you can have all the pulmonary veins draining into a confluence. Okay. And this will go and open into the coronary sinus. So the four pulmonary veins drain into a confluence. This confluence goes and opens into the coronary sinus. So cardiac TAPVC is also causes a dilated coronary sinus. So the answer is LV dysfunction. Again, requires you to have some knowledge on anatomy, but again, this can also be answered used on logic. So again, unroofed coronary sinus, blood flow from the LA into the coronary sinus, there is going to be dilation. LSVC drains where? Into the coronary sinus, there is going to be coronary sinus dilation to increase blood flow. TAPVC, cardiac TAPVC, the confluence of the pulmonary veins drains into the coronary sinus, is going to be dilated. Remember, RV dysfunction, it is the most common cause of CS dilation. So RV dysfunction, RV failure, it is the most common cause of CS dilation, not LV dysfunction. So why is that? So the coronary sinus opens where? The coronary sinus opens into the RA. When you have RV dysfunction, the pressures are going to increase. The RA, there's going to be tricuspid regurgitation. The RA pressure is going to increase. When the RA pressure increases to very high levels, the coronary sinus finds it difficult to empty, thereby it dilates. So remember, RA pressure is increased to very high levels in RV dysfunction. The coronary sinus finds it difficult to empty into the RA, thereby the RA pressure in the coronary sinus dilates. The most common cause of dilated coronary sinus is RV dysfunction. So when you see a dilated coronary sinus on your echo, look for RV dysfunction. If there is no RV dysfunction, you have to look for an LSVC and unroofed coronary sinus. So remember, difficult, but again, it requires you to have some knowledge on anatomy again, but that can be answered also. So 11th question here. So again, venous drainage of heart. So I'll take this opportunity to tell you about the venous drainage of heart. The coronary sinus has many tributaries. You have the great cardiac vein, you have the middle cardiac vein, you have the small cardiac vein, you have the oblique vein of LA, you have the posterior vein of LV. Okay, so you have many tributaries of the coronary sinus. The great cardiac vein accompanies the LAD. So again, in the anterior interventricular group, LAD is closest to the anterior interventricular group. The great cardiac vein accompanies the LAD. The middle cardiac vein accompanies the posterior descending artery, which can arise either from the LCX or the RCA. It accompanies the posterior descending artery. Okay, the small cardiac vein accompanies the RCA. Okay, you have the oblique vein of left atrium and the posterior vein of LV. But remember, the great cardiac vein accompanies the LAD, the middle cardiac vein accompanies the PDA, the small cardiac vein accompanies the RCA. Why is this important? When you do a CABG, a coronary artery bypass graft, suppose I do a CABG and I want to put a graft to the LAD. So what do? I take the radial artery or I take the mammary artery and I stitch it to the LAD. Some people have accidentally stitched it to the great cardiac vein. So instead of stitching it to the LAD, sometimes some surgeons have accidentally stitched it to the great cardiac vein. That is why you will find two vessels in the anti-enteral groove. You must separate which is the artery and which is the vein, because you might accidentally anastomose it to a vein. Thereby two problems occurred. One, the LAD is still blocked. Two is you have created an AV malformation. Okay, the LAD which is occluded is still occluded, but you have now stitched an artery to the great cardiac vein. You have now created an AV malformation and this patient can go in for heart failure. That is why. So when you are putting a graft to the PDA, when you are putting a graft to the RCA, when you are putting a graft to the LAD, remember veins are also seen in these grooves. So when you anastomose the LAD, you will find two vessels in the anti-enteral groove. You have to know which is the LAD and which is the great cardiac vein and put the graft to the LAD, not the great cardiac vein. The same thing applies to the middle cardiac and the small cardiac vein also. This has been asked. So which vein accompanies which artery? So and what drains the RV, RS and GV punt? It is the anterior cardiac veins. Okay, anterior cardiac veins do not drain into the coronary sinus. They drain from the RV and open up into the RA. They receive blood from the RV, open up into the RA. And Thebasian veins of venae caudae minimus, they are small veins and they drain the corresponding chambers LA, RA, LV and RV. Okay. So again, this is very important. MCQs have been asked from this. Okay, this is the coronary sinus. It's located posteriorly. Okay, coronary sinus is located in the left AV groove. Okay. The right, the small cardiac vein here, it is located in the right AV groove. And what causes the right AV groove? It is the RCA. The great cardiac vein is located in the anterior interventricular groove. And what causes here? It is the LAD. Okay. The middle cardiac vein is posteriorly. It is located in the posterior interventricular groove. And what causes here? It is the PDA, which can originate either from the LCX or RCA or both, depending on the dominance. So again, here you can see the anterior cardiac veins open from the RV, drain into the RA. Again, directly drains. So again, this is the fenestrated coronary sinus, just showing you this. Veins that do not drain into the coronary sinus, they are Thebasian veins, anterior cardinal veins and marginal veins. So these are the veins which do not drain into the coronary sinus. So again, we finished this module. So I've shown you there are around 11 questions which have been asked in AIMS 2021. Okay, which can be answered based on logic. Okay, again, you need not have read on that particular topic. For example, the PA banding question. We don't know the indications of PA banding, but you can utilize a rationale in order to gauge the answer. So it is still possible to guess the right answer using logic or at least eliminate a couple of options. It is not possible in an exam like PJ where there are multiple right answers and multiple wrong answers. But remember, in the other exams, it is still possible to guess the right answer using logic or eliminate at least a couple of options. So please remember, just because you have not read the topic does not mean that you cannot answer the question. If the question seems tough to you, remember the examiner might not be expecting you to know that particular topic. He might be expecting you to rationalize and find out a suitable answer. So please remember, it is still possible to guess the right answer using logic or at least eliminate a couple of options. So if you like this particular video, I suggest that you have a look at this video the day before the exams. It might prove useful. At least the methodology might prove useful. So very important point. When everyone else is losing their heads, it is important that you keep yours. So in your exam hall, when everyone else is tense and anxious and losing their heads, it is important to keep yours. And remember, calmness in your exam hall, okay, will help you gain a lot of questions, will help you prevent unnecessary mistakes, and might help you even answer questions in topics which you have not read also. So this was said by Marie Antoinette, okay, and ultimately she lost her own head on the guillotine in the French Revolution. This is actually said in another context. If you go one slide back, you will know what it is. This is said in another context. I just put it here for the exam purpose. Okay. With this, we come to the end of the presentation. Thank you.